Hello, everyone. I'm Lauren Piercy with the Council on Developmental Disabilities, and I'm here with my colleague Mandy Pellegrin with the Sycamore Institute. Both of our titles are policy directors, and we wanted to just have a conversation today that we could share with you all and talk about the facts of what is called TennCare III, or sometimes referred to as a block grant, and has gotten a lot of attention in the media and in advocacy circles. And we really want people who are directly impacted by these changes to understand exactly what's happening, what the risks are, what the opportunities are, and where you can find more information after today. So Mandy, in her role at the Sycamore Institute, has done a really thorough analysis, has read the entire waiver document, and both of us have participated in the public meetings. And so we want to share with you sort of what my questions still are. And then Mandy will go through a document that the Sycamore Institute put out. You all can review it, and we'll answer my questions. And then most importantly, at the end of this, we will be able to invite you all to sign up for live Q&A sessions with Mandy, and we will be able to have further discussions with you. But today we're going to start with just an overview of the basics. It is going to be geared toward the disability community here in Tennessee, knowing that the disability community is one of the largest populations that use Medicaid, and the Medicaid services, particularly in long-term services and supports, are really a critical lifeline to people with disabilities, particularly developmental disabilities. So we know this directly impacts you, and we want you to be able to understand exactly what's happening. So without further ado, I think, Mandy, I will just start by asking you, tell us about how Medicaid typically works and how Medicaid will begin to work under the changes that we're going to refer to as TennCare III.
Great, thanks for having me. First of all, I'm excited to share with you kind of the work that we've been doing on this to understand it. First, I want to back really far up and talk about the difference between an entitlement and a block grant, just in the traditional term, Medicaid aside. So I guess I'll ask you a question. When you hear the term entitlement, what is a program that comes to mind for you?
Social Security comes to mind. Any program that doesn't have, a set limit that people can get because they qualify for it, because they're entitled for it.
Yeah, that's right. So you'll often hear people also call them open-ended entitlements. And really what an entitlement is it's a federal funding concept. So it means that the federal government has to pay for it no matter how much it costs. So it's not limited by some specific number that Congress decides each year. So kind of in federal budgetary talk, there's entitlements and there's discretionary spending. So discretionary is where they're kind of putting caps on things every year. And entitlement is, we're just paying out benefits as the federal government without any sort of budget per se on it. But then there are the programs that people think of as entitlements that do fit within that. And those are things like Social Security, like you said, Medicare, and traditional Medicaid. So these are really kind of like entitlements to individuals, people that meet the qualifications for those programs. They're entitled to the benefits of those programs, whether it's a check or some set of services, regardless of how much it costs. And there are some exceptions to this, which we'll get into in a minute, but Medicaid is kind of interesting because it's also an entitlement to states. So not just individuals, but states. States run their own Medicaid programs under federal rules, but the federal government pays for part of it. And states are entitled to that federal share no matter how much they spend. So in providing these benefits to people, the state is the one paying for it, and they're entitled to this federal funding. So it's an entitlement to individuals. And again, with some exceptions that we're going to talk about in a minute, it's also an entitlement to states. So on the flip side of that is, well, not really on the flip side, it's just a different concept, is block grants. So the traditional term block grant has really a couple of defining characteristics, I'd say. First, it's just a lump sum of federal money that usually goes to states. Really, like any grant, it's a defined amount of money. And two, it's usually for some broad purpose so that states have some flexibility to do the things that they think works best for them. And you're dead on. Some of the biggest and well-known block grants are the Community Development Block Grant, the Substance Abuse Block Grant, the Mental Health Block Grant, Child Care Block Grant. And so these are all discretionary programs. So they work under that annual spending bill that Congress has to pass. There are caps on the overall program, and then there are caps on the individual grants that go to states. So I think that's kind of an interesting place to start. So just sort of put those traditional concepts of entitlements and block grants in the back of your mind. And I'll kind of round back to that later. So now I'm going to kind of move on to TennCare's long-standing financial structure. So this is how TennCare has been funded basically since 1994. And I think it's really important to understand how the financing of all of this works, because it's really what ultimately determines the risk and shapes the incentives that are facing policymakers under this new agreement. Now, I'm about to get really far into the weeds here, but I do think it is important to understand so that folks can really understand what exactly is changing here for Tennessee. So in the traditional sense, Medicaid is an entitlement. Federal Medicaid law lays out all sorts of required benefits and populations and optional benefits and populations. So if states follow those parameters that are in the federal law to a T, the program largely works like most entitlements. The state spends what it spends on those things, and the federal government matches it. Every state has a different match rate depending on what incomes are like in that state compared to other states. Tennessee's is usually around 65%. That's called our FMAP, and that's what the federal government covers. So that means the federal government is covering about 65% of everything that Tennessee spends on Medicaid. Now, TennCare is not traditional Medicaid. In addition to these like mandatory and optional things that are already laid out in federal law, the same federal law allows states to seek out what are called waivers, so long as it accomplishes the objectives of the program. So what happens under a waiver is a state gets permission to deviate from some of the specific requirements that are laid out in federal law. And states use waivers for all different kinds of things, some of them broad and some of them narrow. And I know that you can connect the dots for your folks, certainly with waivers, because a lot of long-term services and supports are predicated on these waivers. So some examples of how states use waivers are to provide benefits to people that might not otherwise be eligible. Maybe they provide benefits that are not otherwise provided. So actually home and community-based services is a really good example of that. A lot of states use waivers for that, or they might use a waiver to provide or pay for care in some innovative way. So TennCare has actually operated under a waiver since 1994, and the core of that original waiver was that it allowed private health insurance companies to administer benefits. So this is what we call managed care. So before this, no state had really used private health insurance companies to administer these benefits. And the thinking at the time was that by using managed care, the state would save money on its traditional Medicaid population, and then it could use that money to enroll new groups without spending any more money of its own money or the federal government's money. You know, TennCare has been through iterations since then, but it still operates under a waiver, and it still has a lot of the same financial components to it.
And Mandy,
I was going to say, stop me if I'm going too fast.
No, you're not going too fast, but for people who are familiar with waivers, they're kind of the waiver within our waiver. So what you're describing is the entire TennCare program is under a waiver since 1994. And before and after that, including today, there are also waivers, 1915C waivers that serve people with intellectual disabilities. And then part of our big demonstration waiver, we also use the terminology, the ECF choices waiver, the choices waiver, which are technically not different waivers, but terminology is part of our vernacular. So I think you're making a really important point that we are already operating in a non-entitlement type of Medicaid program under this structure. And that is certainly directly impacting people with intellectual and developmental disabilities.
Yeah, that's right. So, yeah, so there's lots of different kinds of waivers. 1115 is our main one, but we do have others, but it does include like choices and the new Katie Beckett program, things like that. And actually, I think 45 states have some kind of 1115 waiver in place. At least one waiver, some have multiple, and sometimes they're really narrow, like they may choose to do something like just choices in a single waiver. And some of them are very broad, like ours, which basically is the whole, TennCare program. So an important component of these 1115 waivers is what is called budget neutrality. So this is a terminology I'll probably use a lot, but budget neutrality essentially shields the federal government from the financial risk of entering into these waivers. So each waiver that the federal government approves has what's called a budget neutrality cap. And that's based on a calculation of what the federal government might have spent on the state if that waiver had not been in place. So if it was just following federal law to a T. So funding up to that cap works in generally the same way as traditional Medicaid funding. So as the state spends money on TennCare, the federal government is covering 65% of it. Now, if a state were to exceed its budget neutrality cap, it must cover those costs out of its own pocket. So it's working the same general way up to the cap, and then the state is at risk for anything above the cap. So really what this means is that TennCare has been subject to a federal funding limit since the program was first established in 1994. So a long-standing federal funding limit. I'm going to put up an animation here as I kind of walk through how that gets calculated. So first they consider each eligibility group individually. You have children, adults, individuals with disabilities, those over 65, and then those who are enrolled in both Medicare and Medicaid. Those are kind of the 5 big buckets. Then there is some base per person costs. So the average cost to cover a person in each of those groups. Then they take that base amount for each of the different groups and they trend it forward by some annual growth factor for that specific group. So every group has a different base amount and a different trend amount. The per capita amount for the relevant year gets multiplied by however many people end up signing up in that particular eligibility category. And then all of these things get added together, and that resulting number is the budget neutrality cap. So it's kind of a single number with all these different inputs that go into it. Now, the federal government in Tennessee will cover about 65% of anything up to that cap. And then again, over that, the state has to cover 100% of it. So you might ask, Lauren, how financially risky has this cap been for the state in the past? In recent history, it has not been very risky. First of all, the per capita costs and the annual growth rates that feed into the cap, so those kind of 2 middle columns in the graphic, they're pretty generous compared to what the state's actual costs have been. There are some exceptions when you kind of start digging into specific years or specific groups, but the state has really had no problem meeting those expectations in recent history. And then you layer on top of that, let's say that we exceeded our cap 1 year. Well, we could use, quote, savings, so amount under that cap, that we got in another year. We could roll those over and make that count towards our cap. And we've been able to roll those savings over for years now, really coming up on a couple of decades. So we never exceed the cap, and we've just been accumulating these savings, we being the state. I'm a Tennessean, so I can say we, but accumulating these savings that can count towards the risk that the state faces under the cap. So the point here is that TennCare has had a cap in place for a very, very long time, but it has never posed much of a financial risk to the state.
And Mandy, why wouldn't we move closer to that cap and spend more? Is that a decision we could, in theory, make?
I mean, in theory, so a lot of the way that waivers work too is that you have this cap in place so that if you were to quote produce savings for the people that are, the core of the program, you could then use those federal savings in the traditional Medicaid sense to pay for new benefits or new populations, which was kind of how the original TennCare waiver worked too. We're in a balanced budget state, so there's already a pretty strong incentive to keep the program fairly efficient. It is most states' largest expense when you look at all revenue sources in Tennessee. It's second behind K through 12 education when you're looking at just the state's own tax dollars. So that's a big chunk of money, a balanced budget state. So there's already quite a bit of incentive to be kind of fiscally prudent with the program and to look for efficiencies where you can, I guess, as an administrator.
And coming up with that other 35% is not a small feat, even though.
No. We're talking about billions of dollars. Right. Yeah. So I think I'm going to back up again before I jump into what is in this agreement and talk a little bit about some changes that were coming down the pike to that complicated formula that I walked you through. So both the Obama and the Trump administrations, so going back to 2016, had announced that they were going to change some of the way that they did those budget neutrality calculations moving forward. So our last waiver as a state was renewed in 2016, and all of those changes have been announced since that time. So they didn't affect Tennessee's cap in the past, but they would have affected the cap moving forward, and TennCare's waiver expires in 2021. So all of this was potentially going to affect TennCare's waiver renewal this year, assuming that the federal government followed this new guidance that had been put forth by the last two administrations, to a T. And really, there were two big changes to that guidance. And the first was that they were going to rebase those per capita costs and annual growth rates to each state's most recent trends. And two, they were going to limit states' ability to keep rolling over old savings to use in the future if they exceeded their caps. This was going to be a pretty big deal for Tennessee. Both Tennessee's per capita costs and our annual growth rates have been relatively low compared to other states. So Tennessee would basically be held to an already very low cost and low cost trend moving forward. And at the same time would not have had the benefit of years and years of savings to cushion it if it couldn't do those things, if it couldn't stay in line with its low cost trends. Okay. I think that's all the background you need to begin to explain moving forward.
And one more question. Usually every 5 years, there's a big renewal process that you just mentioned. This is maybe getting ahead, but is it unusual that the next change is asking for a 10-year renewal?
That's very unusual. I think Tennessee is only the second state to have gotten a 10-year renewal. And we'll go into why that's important here in just a minute. Okay, so here's how the funding works under the TennCare III waiver. It pretty much works the same as it always has in its fundamental structure. So all those same variables in that complicated formula are, that all looks pretty much the same. But there are three exceptions that are sort of new. So the first is that the things that go into that per capita amount and those annual growth rates do bring it more in line with that new guidance that I talked about. So they're not as advantageous as our old deal was, as the calculation that fed our old cap, but they actually are better than what Tennessee might have gotten if the federal government had followed that new guidance word for word. And I'll get into that a little bit more in a second. The second big exception is that the cap won't change from year to year unless enrollment in any one of those groups is more or less than 1% of what it was in 2019. So there is a band in which the cap will not change based on enrollment, and it's 1% more or 1% less than 2019, and that is applied within those eligibility group levels. And that's important because the mix of enrollees changing is important. And actually in the paper, there's a graphic that you'll see that plus minus 1% is a pretty narrow band of enrollment change. And then the third big exception, what's changing with the funding, is that if we stay under the cap, the state can draw down as much as half of the federal portion of that savings without spending any new state dollars. So now, you know, any difference between the cap and state spending, that's just savings where Tennessee gets 35% of it and the federal government gets 65%. But under this agreement, depending on how the state performed on some quality measures, it could potentially get up to 55% of that federal portion back to the state.
What you're describing does sound like some fundamental differences. How is it different than what we think of traditionally as a block grant? To go back to our original conversation about how that's really a finite amount of money given to the state.
Yeah. You know, strictly speaking, this is not a traditional block grant, not like the kind that we talked about earlier. I'll also say in 2017, Congress, the US Congress, was considering a block grant option for Medicaid. And I would say that this is also quite different from that as well. You know, so why is it a block grant? You know, there is a funding limit and it is a single amount that's based on all those things we talked about earlier. I think a really important difference, though, is that the amount does change with enrollment if there are large increases or decreases, or actually relatively small ones. I'll also add that the Medicaid block grant debate that was going on nationally in 2017 was very much focused on generating savings for the federal government. It was a trade-off. It was, we get more predictable spending at the federal level that's constrained, and in exchange, we give you, the states, more flexibility. So it was a trade-off, and it was specifically focused on generating federal savings, holding states to lower spending growth than they had in the past, essentially. And this agreement is not necessarily looking to do that. So I kind of want to sum all this up and in this part of sort of the funding conversation with some comparisons and some simplified visuals. So I'm going to throw up an animation again. These are not real numbers. This is just sort of a graphical representation of sort of the mechanics at play and how that compares to the financing structure that we were under and how it compares to the financing structure we might have been under if we went up for a renewal and the federal government followed that guidance that I talked about that had been put out since 2016. So let's pretend that this line right here represents the budget neutrality cap that TennCare was subject to in the past. And this line is what actual TennCare spending looked like in the past, so always well below that cap. Now let's assume that TennCare spending stays on about the same path moving forward. Under that new guidance I talked about, this budget neutrality cap would have been rebased to the state's actual costs. Its growth would have been pegged to the state's actual growth. And then it would have been rebased every 5 years. And then any savings from being under the cap in those prior years likely would have only been available during that first 5-year period. And here's what happened instead under the TennCare III agreement. So the state's costs will still be rebased every 5 years based on the state's own spending. But the growth rates will be pegged to national projections, not Tennessee's own experience. And the savings from the prior period will be available for all 10 years of the waiver in case we do get close to that cap. And then finally, if Tennessee stays below the cap, the state could access up to 55% of the federal share of the savings without spending any more state money. So I hope that visual kind of helps bring to life kind of the words that I'm saying.
It did, and it helped to hear you talk through the visual with the context of how the regulations were changing regardless, how our TennCare waiver worked under a neutrality cap.
Mm-hmm.
You rolled over that savings each year, regardless of the changes. And most importantly, those three things about how this is, a huge change
Mm-hmm.
that this particular negotiation is bringing about that is pretty unprecedented
That's
from
right, yeah.
your typical negotiations for a renewal.
Yeah. I'm glad that was helpful. It's a lot of asides and background, but I think in this particular situation, it's kind of important to be able to really understand what's changing.
I agree. And so now we're going to shift gears from the context setting to really looking at the details of what this new 10-year renewal will look like under TennCare III or block grant. So can you walk us through, Mandy, and you're on the document that the Sycamore Institute put out, there's a box of key takeaways. And if you could tick through those and just give us a little bit of your own narration, if you will, on each, that would be really helpful.
Sure. So kind of the frame that we used for the paper was comparing what the agreement looks like compared to a typical TennCare II renewal and what that might have looked like. So previous program, the one that we all know is TennCare II. Like I said, it was up for renewal in June of 2021. So basically we looked at what that might have looked like if it had gotten renewed based on new guidance from the federal government and all that. So things that might have changed since the last time. And we compared it to what was actually in this TennCare III agreement. So the first, which I just kind of went through, is that Tennessee may get more federal Medicaid dollars without spending any new state money. So I kind of talked about the mechanism of the percentages and all that. So if we stay below that cap, the state could get up to 55% of the federal share of that sort of back. And the way that would work is there'd be a range, 55% sort of the cap, and it's 45 to 55. It could go lower than 45 or not be there at all based on how the state performs on 10 quality metrics. Those metrics have not been chosen yet, but they will be chosen moving forward, and they will be from, Medicaid's existing set of quality metrics that states already have to report on. So they would only get the maximum amount if the state was improving on, some number of metrics. I can't recall the exact details off the top of my head, and then the way that we would get access to this money, because a lot of folks have been concerned that this steps around sort of that core funding structure that I talked about, the entitlement piece, the 65-35. Well, how could Tennessee draw down more federal dollars if it's not meeting its 35% requirement? And the way that they have built that out in this waiver is that money that Tennessee is already spending on health-related programs that are not in TennCare today, so they're fully state-funded programs, would essentially count as match. And the federal government would start funding parts of those programs. So it would essentially it could free up as much as 65% of how much the state is spending today on these programs. And those programs it's like a limited set that's laid out in the waiver, and Tennessee would have to go back and get federal approval if they wanted to change that list. So essentially what's happening is it's buying out state spending on existing programs and freeing up state dollars. Now, the waiver does not have any restrictions on how those freed up dollars have to be used, because, those are the state's own dollars now. So I'm not even sure that they could tell us how to use them. So I'm kind of, sorry, sticking too long on point one, but there's a lot to it. I think this one is a lot of interest to people, and there's a reason that's number one on our takeaway list is, so TennCare has committed to using those freed up dollars on kind of expansions to the existing TennCare program. They've done this sort of in press releases. Some of these things were laid out in the initial proposal to the federal government, and then they've even included some of them in recent budget requests, even before this waiver was required. And some of those things include extending TennCare coverage for women after they've had babies, so for a full year of coverage, extending dental care to pregnant women. And then another one is sort of buying down or reducing the wait list for the Choices programs, which was something that was in the budget last year before the pandemic hit. So, you know, they've committed to doing these things, but there's not necessarily anything in the waiver that requires them to do those things. Two, so this is another really a lot of this is about what if and what might happen in the future. But there are some very concrete things, limited concrete things. And one of them is that TennCare will be able to limit the coverage of some prescription drugs in what's called a restricted drug formulary, which is a common practice in private insurance and Medicare, but it's never before been allowed in Medicaid. So this is probably one of the most unprecedented pieces of this agreement, is the ability for the state to use a restricted drug formulary. And I think that will take some time to build out, and there will be exceptions processes and all that that have been spoken to in the waiver, but there are no specifics at this point on what that will look like. Then go ahead.
Oh, I was just going to say, this is one of those points where this might directly impact you if you're watching this. And I would encourage you to share your stories or your concerns with us, and we can help direct you to make sure that people who are making these decisions are aware of what you're concerned about and able to answer questions or use your experience to help make better decisions. So I might interject every once in a while, Mandy, to point out some of those opportunities.
Sure. I think it's helpful for you to provide, you know, context that's helpful for your audience. So the third takeaway is the state would not need federal approval for any changes that keep TennCare eligibility and benefits at or above end of 2020 levels. So there's basically two things going on in this one takeaway. One is new flexibility, and two is a maintenance of effort requirement. So in the past, the things that are approved in these waivers are usually very specific. And if you know, very specific about who's being added, very specific about what benefits are being added. And if a state wants to change any of those things, it has to go back to the federal government and do what's called an amendment process, where they go through a negotiation to get federal approval to sort of change the parameters of their waiver. Also, this is an unprecedented sort of part of this, is that if the state wants to use any existing optional flexibilities that are sort of in the Medicaid law, that are additive in nature compared to December 30, 2020. So add a new benefit, add a new population, they can do that. They don't need to go to the federal government to get permission to do that. They'll still have to go through some transparency requirements, public comment periods, public hearing type things, but they won't need approval to do that. And they won't need approval to roll those things back either. So anything they add, they could take away as well. I think the thought there is that they would like more flexibility to experiment, to see if things work, and to see if they produce cost savings, or to see if they produce better outcomes, and then to be able to quickly scale up or scale back, depending on what they find. So the other kind of piece of that is the maintenance of effort requirements. So there is a floor for how that flexibility can be used, and that floor is whoever was eligible, whatever was covered as of December 30th, 2020, you know, those people, those enrollee categories, those benefits cannot be rolled back without going through the same process the state has always had to go through. Okay, so the fourth takeaway, which I won't dwell on this for too long because we just spent what, 20, 30 minutes on it, is because of changes in federal policy, the new federal funding cap under the TennCare III agreement may actually pose less financial risk to Tennessee than a renewal of the existing program. Again, I won't dwell on that because we just went through visuals and all that. The fifth takeaway is the new shared savings provisions add to the state's existing financial incentive to reduce TennCare spending. It basically ups the value of finding savings in the program. So because of the way that the shared savings work, finding savings in TennCare would essentially free up more state dollars for other things than it does today, if that makes sense.
It does. And sometimes we translate savings to cuts in our mind. So can you talk about how what the risks or protections in the framework are for that?
So again, whatever the state does to find savings is limited by this maintenance of effort requirement. So anything that would officially roll back a benefit, would officially roll back an eligibility category, not only could they not do it without approval, but if they did get approval to do it, that would adjust the cap, and so it wouldn't actually produce any savings. Now, there might be some things that the state could do to find efficiencies kind of that don't meet that strict maintenance of effort requirement. You know, there's not a lot of specifics around what the standard is for that maintenance of effort requirement. So, you know, there might be efficiencies that the program could find that would produce these types of shared savings. Obviously, the formulary is more than likely going to produce quite a bit of savings. That's the, you know, kind of the main purpose of it. If you ever wanted to sort of learn, well, what are the ways that TennCare finds savings each year, you know, go to the annual budget document, and there's lots of little administrative things that seem to happen every year that produce savings, streamlining a system or something like that. Okay, so finally, the sixth difference from what a TennCare II renewal might have looked like is that if policymakers wanted to roll back TennCare III, it could take longer than prior waivers. So a waiver is essentially an agreement between the federal government and the state government. So either party could come, you know, back to the table and say, no thanks, but they would need a good reason because it is an agreement. And as we talked about earlier, most waivers are 3 to 5 years. Typically ours have been 5 in the past, sometimes they're 3, but there's, you know, other than this new waiver and one other one, there's never been a waiver that's more than 5 years. And so obviously the waiver expiration date forces both parties back to the table to kind of renegotiate what it'll look like going forward. This waiver is in effect for 10 years, so there's no forcing back to the table for at least 10 years. At the same time, you know, there really hasn't been a wholesale, there hasn't been a time in the past where the federal government has had a huge problem with a waiver that it approves such that it would go back and say no and take the whole thing back. But obviously there's a lot of talk that a Biden administration could do that very thing because this is, you know, conceptually it's very tied to the Trump administration. As sort of the Biden or Trump administration was on its way out, it issued some guidance to states, sort of an agreement letter laying out a process for what would happen if that were to happen, like what the state would have a certain amount of time to do appeals. And that process is basically no shorter than 9 months. So that at least slows it down to that extent. Now, I can't really speak to whether or not the Biden administration could also roll that guidance back. I'm not sure. A lot of Medicaid policy happens sort of what one might call sub-regulatory policy. So through letters to states and memos to states, and, you know, because the federal law tends to be broad in some areas, allowing each administration to sort of fill in the details. So that's what we mean sort of by that sixth difference. Then we have 3 takeaways that are sort of outside of the differences. The first really thinks about how these new flexibilities and the finance piece work together. And the way those things work together is it kind of creates an unprecedented and complex set of new incentives and opportunities for state policymakers. So you have more flexibility to potentially find ways to save money. The value of saving money is now increased. So those things sort of work together in complex ways that I'm sure will be dealt with kind of on a case-by-case basis moving forward. But because it does create this new set of incentives and flexibilities that aren't necessarily laid out today, it does create new uncertainties for people that are enrolled in the program today and for people who may enroll in the program later if they use these flexibilities to expand services and eligible groups. So, I'm sure you can sort of speak to some of those feelings a little bit better than I can. Then the next takeaway is that, there's been a lot of talk about Medicaid expansion and whether or not this basically has anything to do with it. And really, it doesn't explicitly address or preclude a comprehensive expansion of eligibility under the Affordable Care Act to all adults who are under 138% of poverty, if state policymakers wanted to pursue that kind of thing. The shared savings could certainly be used to do some incremental expansions of benefits or eligibility, things like that. But the kind of wholesale expansion envisioned under the ACA likely couldn't be done with the types of savings we might be looking at under this. And the state wouldn't be able to tap into the higher match rate that's available under the Affordable Care Act without actually going back to the federal government for a formal approval process. So, it's related but unrelated. I think if policymakers ever wanted to revisit that would just follow a separate process. And I don't think there's anything in this that I see that would necessarily preclude that from happening. And then finally, and I kind of just got into this a bit, the Biden administration could certainly rescind approval, but the Trump administration did take steps to lengthen that process. And then, of course, at the same time, the program will almost certainly face some kind of legal challenge in state and or federal court. We certainly can't speak to the specifics of that, but have certainly seen talk of it and talk of it even before the waiver was approved.
So at the end of the day, thank you for pointing out the key things that have changed and giving us context about what really hasn't. Is this a good thing or a bad thing?
We really can't say that for certain. Will it ultimately be good or bad for the state, for healthcare providers, for patients on the program? It really all depends on decisions that are made moving forward. How will the state continue to manage TennCare costs to stay under these rebased caps? Will they be able to share in any savings that they produce? Will the formulary and exceptions process, what will that look like? How will TennCare use the new flexibilities that it has? All of those things we cannot predict. We don't have a magic ball, and it'll just depend. But I think that those who are interested in the program and those who depend on it, they'll need to stay engaged. Work with the state as it sorts out the details, as it sets its priority for using the flexibilities. I think that, we have to treat this as if this is the new policy in Tennessee without, worrying about what the federal government is going to do at this point. And so I think engagement and attention is really what will be important for those that really depend on this program.
I think that was so well said. And for people in the disability community, please feel free to, if you're not sure how to engage, use the Council on Developmental Disabilities as a resource. We're here to help elevate your voices to the decision makers. And so we'll have a slide at the end of this with my contact information. You can certainly also follow up with the Sycamore Institute on details about the overall analysis that they've done, and really encourage you to sign briefs because they have such a good, clear, and visual nonpartisan analysis that can help us all understand what's changing